Labral tears on a hip MRI are considered to be somewhat difficult to assess for radiologists. And when I was a resident, I learned about labral tears in the hip like everybody else, and for me, how I was taught, it was quite easy. Everything in the anterosuperior quadrant is a labral tear. But then you see these research articles where 50%, up to 80% or even more of asymptomatic people, athletes, they all seem to have a labral tear. So something is not really adding up, right? If everybody has it, it's probably not a real pathology. So what's going on here? In this lecture, I will take you to a journey down a rabbit hole and I will deep dive into the literature. We're gonna have a look at the research articles that talked about labral tears, the way they use the classification systems, the way they decided where to look for the labral tears. And I wanna answer the question, are we looking at the right location? So let's dive in. Hello everybody and welcome to today's lecture. My name is Chris and I'm really happy to be here today. Thank you very much to Vancouver Bone Squad for the invitation. I'm really honored. It's a series I follow throughout the year. I watch multiple of these lectures and I'm keep learning from all these great lectures and speakers that you're inviting. So I'm really honored to be here and presenting myself today. The topic of today's lecture is acetabular labral tears. Are we looking at the right location? And I will take you to a journey down a rabbit hole and I will explain what that means here just in a bit. I would have loved to do this live, but yeah, I have 3 little children and I live in Abu Dhabi and sleep is kind of like my most precious resource at the moment. So I decided to do this as a recording. But nevertheless, it's not going to change the content. So I'm going to switch on here the presenter mode. So there we go. Let's jump right in. Just a little disclaimer before we go. I have a YouTube channel, in case you don't know. It's a MSK Radiology YouTube channel with over 27,000 subscribers, a bit over 200 videos about MSK MRI mostly. And funny enough, you can see the second most watched video with 61,000 views is about labral tears of the hip. So this is kind of like the topic that we will be talking about today. Before we dive into the learning objectives and the content of the session, I want to frame or pre-frame this lecture with some numbers. The prevalence of asymptomatic labral tears is really high, and this is astonishing. If you look at these individual studies, I just took a couple of them here, 40%, 70%, 70%, 80% in volunteers, in military people, young athletes, and so on. And in a meta-analysis, the overall prevalence of asymptomatic labral tears was over 50%. So every second person has a labral tear but no symptoms. It seems to be a bit lower in younger populations, but then again, resolution, imaging protocols might also play a role. But yeah, every second person has a labral tear but no symptoms. And when I saw these numbers, you start to ask questions. So the first question that I had was, if most people have something and it's not really symptomatic, is it really a pathology or is it maybe something else? And then I had an epiphany, I want to call it. I think it was 2019, where I had a case which started an internal discussion with myself and with my surgeon that I work with at the time, to really look at the same thing. I mean, radiologists and orthopedic surgeons. So we will have a look at this today as well. And if we don't look at the same thing, what are we actually calling tears? Are these variants? Like, what's going on? So these are a couple of questions that I try to answer in today's lecture. And when I was in residency and even in my fellowship, I learned hip MRI the easy way. I call it the easy way because there is at least one study that showed that 84% of all labral tears occur in the anterosuperior quadrant and the remaining 16% in the supraposterior quadrant. Hardly ever any tears in the inferior quadrants down here. So that's super easy. And I remember the attending who was 1 or 2 years in front of me while I was a resident, and he taught me this. Everything anterosuperior quadrant, just call it a labral tear. And this made it really easy to analyze the hip labrum, as you can imagine. Some line, anterosuperior labrum, it was a tear. And I kept doing this for many years. And we will later go back to this and see if that really holds true. But I want to take you further down the rabbit hole today, show you a world where maybe this easy way doesn't uphold anymore, open your eyes to a potential scenario, although it's not fully I call this the labral paradigm shift. And this is the actual image that started this whole journey for me. In 2019 I got a case, post-op MRI of a hip, of a patient who had arthroscopy before for a labral tear. Whenever I have something with like a scenario like that, I immediately go to the pre-op case if there is one available, just to see if I would have been correct without knowing the arthroscopy report and without knowing the post-op scan. So I go into this pre-op MRI here from an external institution. There was a labral tear, or it was called a labral tear. I agreed, anterosuperior quadrant, easy way, labral tear, bam. Then I go to the post-op MRI. They did labral repair, or debridement rather, no suture, debridement. And then this line, this looks exactly the same in the post-op MRI. And I was kind of like, okay, wait a minute, what's going on here? I thought they did some surgery, and you can clearly see this is exactly the same. There was no surgery done at this location. They did surgery somewhere else, and I will show you this exact case later, and I will explain exactly what was happening. So I was confused. And yeah, the learning objectives for this talk are you should be able to identify and describe acetabular labral tears by the end of this talk, to know the difference between a tear and a variant or a potential pitfall. And I want to start a discussion about the anterosuperior sulcus, or conundrum, as I also like to call it, and we will see why. How I do it, we will talk about the normal labrum. I will briefly talk about the clock method that we use to describe the location of abnormal or even other findings in the labrum. We will briefly summarize the labral variants, pitfalls and tears, how to describe them, what's the terms we can use for that. And then the main part of the talk will be the anterosuperior conundrum, where we also go through some interesting cases together, and then we have some take-home points. Briefly summarizing the normal anatomy, very straightforward. We have the bone, acetabular bone here. We have the cartilage blending in here into the labrum, which has a triangular shape, which is sitting on the outer acetabular ridge here with an attachment onto the bone and onto the cartilage, whereas the cartilage transitions here into the labrum. This is the normal perception of the labrum. And then we have the capsular attachment a little bit higher up here onto the bone, creating this space, which we will later see is the perilabral sulcus. So this is the normal labrum. Now, before we go into any abnormalities or pitfalls or whatever, we need to understand the clock phase method. Now, you might wonder, oh, I've seen this 100 million times, but I'm sure you will not have seen this this way. So the clock phase method, and this is how I was taught in residency, this is how I was taught in fellowship, this is how I've worked for the past year, like decade really. And you can see 3 o'clock is anterior. This was just by definition. I think it makes it easier. 3 o'clock is always anterior, regardless of the laterality. So this explains why 9 o'clock is here. It's not actually a true clock. But yeah, you understand. 3 o'clock is anterior, 12 o'clock superior, 6 o'clock inferior, 9 o'clock posterior, creating the anterosuperior quadrant, posterosuperior quadrant, posterior inferior, and anteroinferior quadrant. So far, so good. So then I was preparing this talk, and I had this idea that I want to talk about the anterosuperior quadrant and recess at that location. And I was quite sure, okay, there's something going on, but I couldn't really explain why. And while preparing this actual talk, I actually think I found the reason why this is actually happening. And here it is. I saw this article in Radiographics from last year. I looked at these images here, and it took me a while to understand, because I got an uneasy feeling while looking at these images. Something just didn't felt right? So I looked at these images, and then suddenly I thought, okay, wait a minute, these numbers, they look a bit off, like they're a bit more rotated than I would have loved. And I was thinking, okay, it's in radiographics. This can't be an accident, right? So there must be a reason. And the text actually explains this quite nicely. Actually, put this away. The text explains that the 6 o'clock definition, 6 o'clock position was defined as the center of the transverse ligament here. You can see transverse ligament where we don't have labrum connecting the anterior and posterior parts of the acetabulum. Transverse ligament, center, 6 o'clock. And then obviously you go to the center, you will end up at 12 o'clock. Anteriorly, you have 3 o'clock, posteriorly 9 o'clock, accordingly, with 90-degree angles. What that means, if I put my own understanding of the clock on this image, this is how I am used to use it, right? 12 o'clock high here, anterior, 3 o'clock, 6 inferior. And you can see 6 here, in my understanding, was not in the center of the transverse ligament, which starts here and ends here. So if we put this as a transparent image on the article image, you can see that we are roughly 1 hour off, either too late or too early, however you want to use it. So we're off 1 hour, depending on how we use the clock. So I was kind of like panicking at the time. I remember I prepared this like 2 weeks ago or so. I was panicking and thinking, oh my God, did I do this wrong all the time, like from residency or since 2009 or so? And then I had to check what's going on in the literature as well. So I found another article here in HR from 2013, and you can see, good for me, there is actually an illustration of the clock face method of how I had it in my mind, how I was taught. And you can see 6 o'clock here. It's clearly not in the center of the transverse ligament. 12 o'clock is straight up. 3 o'clock is anterior. So good. But then I go into the web version of the same article. I don't know how this happened, but then I suddenly saw in the same article, they changed the image at some point. And then I had to investigate why. So I found an erratum where one of the readers wrote a letter to the authors mentioning that they used this diagram wrong because the definition of 6 o'clock is the center of the transverse ligament. And he also gave a reference, which I checked, and that this is the actual clock face method. And if you also go back to the description for MRI, where this was, I think, first introduced by Dr. Blankenbaker, it was also described like this, but still, I was taught it this way. So I was wondering, oh, that's strange, because now I realized, okay, there will be a problem here. Like, we're not talking about the same locations anymore, depending on how we use the clock. So then I go further back, article in Radiology many years ago, MR orthography of the hip. This was by the authors from the institution where I did my fellowship and where I worked as a consultant. And I was very pleased to see that they also used this method. So I was not wrong on my end. I was taught this way, and this has been published this way. 6 o'clock straight down, 12 o'clock high up, 9 o'clock. Well, nowadays we use 3 o'clock anteriorly, but here it was just the other way around. Anyways, good. So I wondered, okay, let's see what the orthopedic literature is saying. And so we go into the orthopedic literature here, an article where they describe the locations of sulci and tears in patients arthroscopically or surgically. Not arthroscopically, I think they actually had a fracture and they replaced the hip. So they went in and really paneled this out. And the text described the clock face method as follows. 12 o'clock is pointed slightly posterior to the patient's head. So it's not straight up, it's slightly posterior. And especially 6 o'clock was directed towards the middle of the transverse ligament, which would be here. Okay. They also use the definition of 3 o'clock. There is something like the psoas U they sometimes use, and I think it's also showing up here in the few images that I found about that. So it goes further. Then you go into different articles and you start to see problems occurring. Here, article from HR, we can see 27-year-old woman with an anterior labral tear. So we see 2 images and the arthroscopic confirmation of the labral tear. The first image is an axial image. Maybe it's axial oblique. Anyways, we can see the arrow here. We can see the psoas tendon. So this is a bit higher up than the psoas tendon in my view. That would make it more like anterosuperior. But we'll then understand that it would be an anterior tear if we go in this location based on the clock face method that would use the surgical definition. Oh, anyways, anterior labral tear, they confirm this, but then they show this image, which is a coronal view. They even confirm this here. They show again a line. And then you start to wonder, now wait a minute. They had an anterior labral tear shown on arthroscopy here and confirmed, but this is not anterior, this is superior. But like, what's going on? This image cannot show both things. It's either this or this, and potentially, I'm not sure actually, to be honest. We cannot know. But yeah, I started wondering, okay, because this location and this location is clearly not the same. And so what is the surgeon looking at, and what is the radiologist looking at? Do we see the same thing? Another article here, I'm blending out these because this is really a bit of a crappy article, and I don't want to shame the authors too much. But the idea was great. They had MRI, went to surgery, they correlated the findings on MRI with surgery. And you can see 37 out of 37 cases had a labral tear. So everybody had a labral tear. Great. And then they were all seen also in arthroscopy. So 100% confirmed labral tears. Of the 37 labral tears, 36 of them, so 97%, had an anterosuperior tear. Okay, I can believe that. One case was posterior. And they had 100% agreement surgically regarding the location of these tears. And then they show these images. So you can see here, coronal image, they show this, and the white arrow marked a labral tear, or marked one of these labral tears. Clearly, again, this is not anterosuperior. This is certainly not anterior, and this is superior. So what's going on? I wouldn't even have called this a labral tear. We can see the labrum looks normal. This is a bit of cartilage here. And the article goes on and claims this is a cartilage tear, a defect, and this is a cartilage defect, which clearly is not the case. So I don't think that's true. Hard to say on one image, but I don't think that's a cartilage defect. Anyways, but then you can see a line here under the psoas tendon, which would be anterior, and you can see the labrum looks okay, but here there is no arrow, there's nothing here. If anything, at that time, I would have thought, okay, if anything, I would call this a labral tear, not this. Okay, so yeah. Do we really see and call the same thing the same name? I started wondering, and when I thought about this for some time, I think this is what happens. So, and I showed you this image before with the pre-op and post-op case looking the same. So what I think happens is the radiologist looks at the MRI. He sees this thing. It's in the anterosuperior quadrant. It's completely detached labrum, and they call it a tear. Because we use the radiologist clock, we call it a tear at this point at the 2 o'clock position. Okay, so I mark it here as a yellow star. This is my anterosuperior labral tear from a radiologist's point of view on the MRI. Then the surgeon thinks, great, patient has also the matching symptoms. He goes in, FAI, typical case, he wants to do arthroscopy. He goes in, and then he also sees an anterosuperior labral tear, but a bit higher up. So what happens is the thing here, because as I showed you initially, this was the case where they looked at the surgery higher up, and then they did something. They didn't do anything here, so this looked the same, right? So if I plot this here on the surgical hip surgeon clock, this would fall into the anterior region, and the surgeon potentially thinks, okay, this is in recess, he doesn't bother. Then he sees a tear higher up. Again, from his perspective, he thinks it's 2 o'clock, right? And then he still sees the tear. He doesn't ignore that. He's ignoring the sulcus. He doesn't even describe it. The radiologist goes into the report or talks to the surgeon, and then the surgeon confirms there was an anterosuperior labral tear at 2 o'clock. The radiologist thinks, great, I'm so good, I saw it. The hip surgeon thinks, yeah, you're good because you saw the labral tear. But yeah, they give each other a high five, think they're the greatest chaps that ever lived. But actually the radiologist was wrong because he described something that was potentially not the tear, or was not a tear, in this case confirmed not a tear. The tear was higher up. Radiologist did miss the higher tear at 1 o'clock position, but that's the one that the hip surgeon saw. So yeah, I think this is actually what's happening here. Now we will dive into this a little bit more, because I think at this point you might be confused. I want to first go through variance, pitfalls, and some nomenclature that gives us some better understanding of description, terms we can use, so that we don't get caught up in a language problem. For the labral morphology, we will go through different types. Then we will look at the perilabral sulcus, which I briefly introduced already. We just briefly look at the transverse ligament labral junction sulcus. And then finally, we look at the sublabral recess, or sulcus as it's sometimes called. Now, recess and sulcus, this is another topic. I always wondered, what's the difference? And I asked Gemini here, and he gave me some description, made a lovely table, and in a sense, it came up with this description. A sulcus is like a groove or a valley, and the recess is like a pocket or a pouch. I hope this helps. Well, it doesn't help me. If you know the difference between the recess and the sulcus, please reach out. I'm curious, because some authors make a distinction, some use it interchangeably. I don't know. For the purpose of this talk, I'm just going to call everything a sulcus, okay? So this is the morphology, or these are the different types of morphologies that we can see in normal people, no symptoms whatsoever. Often, or most often, the labrum has a triangular shape. Here in green, up to 70% of people have it. Straight triangle, bam, all good. Then less frequent is a flat labrum or a rounded labrum. Sometimes, rarely, it can also be absent. And with aging, the labrum can change. I think this is also an important thing to understand. The prevalence of these flat and especially the rounded labrum increases the older you get, or the older the patients are in the studies. It can also shrink a little bit, have more like this degenerated appearance. can also be congenitally hypoplastic, and especially in acetabular dysplasia, we can also have hypertrophic labrum. So this is just a different morphology that we could use to describe the shape of the labrum. This is an example of the perilabral sulcus. We can see nicely the anatomy. Again, here we can see the bone, we can see the cartilage blending into the nice triangular labrum here with a cartilage attachment and the bony attachment, and then the joint capsule coming up, inserting higher up onto the acetabular ridge, creating this fluid-filled space, in this case with contrast from arthrography, and we should not mistake this as a tear. I don't think this is a big problem for most people, but just be aware that this is a perilabral sulcus. I think it becomes more important when we look at postoperative imaging, where this can obliterate and we can have adhesions in this location, although even those adhesions are considered to be normal after arthroscopy and not necessarily symptomatic, as opposed to adhesions down onto the osteochondroplasty zone, for example. But that's not for today's talk. The transverse ligament labral junction sulcus, again, this is not like a big pitfall. I think it's just something interesting to know, because we are dealing in the inferior quadrant, so we are far below the equator of the femoral head. This is the psoas tendon coming down, and then the labrum starts to start transitioning into the ligament, which then underneath the head would go over to the posterior side. And there sometimes you can see clefts and tiny pockets of fluid. And this is just a sulcus of this transverse ligament labral junction and not considered to be a labral tear. So because this is, if you follow the easy way method in the green zone here, we're safe, hardly any tears down here anyway, so we don't call it a tear. So it's just not a tear. So let's go to the sublabral sulcus. These sulci have been described in all quadrants. I think this is the first thing we have to accept. There are several studies about this, surgical studies mainly. And apparently 1 in 5 people have at least one sulcus somewhere. And of those people who have a sulcus, 44% are in the antero-superior quadrant. So the easy way method gets a bit tumbling here, right? So it's not so easy anymore. What is a sulcus and what to look for when we are thinking about a sulcus? So a sulcus should always be linear and smooth in terms of its margins. So we should not have like a rigid margin or something. So nice and smooth lines, sharp. The labrum should look normal, and this is very important. So we should not have any adjacent lines into the substance of the labrum. Very nice looking labrum. There is also no just signal change in the labrum substance, like degeneration, etc. There should not be a paralabral cyst at that location. So if we see a ganglion cyst here, that would be a strong indicator that we are actually looking at a labral tear. And it should not have a bony detachment. At least that's what the articles say. So if you have a bony detachment, that's when people start calling it detachment, which is interchangeably used sometimes as a tear. So the easy method here, with 44% of all sulci occurring in that location, doesn't hold up anymore. Like this would be, if we have 44% of 22, that would be like at least 10 in this region, 10 sulci in, or 10% of people would have a sulcus in this location, roughly. Just a rough estimate here, I didn't do the math. But yeah, and this kind of like fits also my personal experience. 1 in 10, maybe even 2 in 10 or something like that would actually have something what I call a sulcus and dislocation, or even a sublabral hole, as we will see later in this talk. So this one here, yeah, we have to wonder. See, we see this, and this is really the tricky bit. So we'll come back to this case in a minute. Before we do, let's talk briefly about labral tears and how to describe them. Normal labrum, just for repetition, sulcus, we talked about that. Next thing that can happen to a labrum would be the degeneration. We don't see any fluid going in, we just see some signal changes and maybe a little bit of a change in morphology, especially like in older people where we are not even concerned about FAI anymore. It's just degeneration, so we can just leave it at that. We can also go with fraying if the morphology, just the shape is a bit abnormal and a bit hazy, we can call fraying, especially if it's a younger patient. Then partial tears or partial detachments are described as such, where you have a detachment from the cartilage and the bone, or partially, it's still attached up here to the bone, and the margins are not nice, as opposed to the previous sulcus where the margins should be nice. So that's considered a partial tear or partial detachment, which can also extend all the way through. So complete tear, complete detachment here at the level of the base. I think this is the classical teaching, and then we have intrasubstance tears, just like that, and then we can also have intrasubstance tears, something like this. or any combination. And if you have an intrasubstance tear combined with a detachment, either partial or complete detachment, then we can call it just a complex tear. No fuss, don't overthink or try to be overly accurate in terms of the description. We just call these complex tear and give the location where we see them, from which o'clock to which o'clock, or at which o'clock if it's only a short segment. I want to highlight that we need to be very mindful to not forget the associated cartilage defects, because I think with the cam and the impingement, the shear forces create actually more of a cartilage lesion, or a lesion at the chondrolabral junction, rather than a true labral tear. Something to keep in mind. And I will come back to that also again at some point with the cases that I will demonstrate. So let's talk about the anterosuperior sulcus conundrum. And this is my favorite topic currently, because there is something is not adding up. This article here, great authors, fairly recent from, I think, last year, and they describe this like this. The presence of an anterosuperior sulcus is considered by some authors as a potential pitfall in the diagnosis of labral tears. That would be, I'm one of those. So I think it's actually a pitfall. The literature is mixed, however, about whether such a sulcus even exists. And they bring 8 references to really make a point here. Like, if you bring 8 references, basically you want to say, this is the thing. We really doubt that this exists as an atomic variant. So it seems to be not clear. Anyways, it is possible that what some authors have identified as an anterosuperior labral sulcus could simply be a healing labral tear, and they cite a study here. However, this study 4242 is from 1995, and I think maybe that's a bit outdated, and we should maybe look at this, and I will also tell you maybe we need to do a new study about this. Anyways, I think this is you could maybe it's a good explanation why some of these would be asymptomatic potentially, and it's certainly a valid hypothesis, but we will see here just in a bit why I think it's something else. Then they go on here in the discussion. Through numerous sulci, though numerous sulci were identified anteriorly, the general trend showed that the more inferior the anterior labral abnormality, the more likely it was to be a variant, a recess or a sulcus. Still, I don't understand the difference. And the more superior the anterior abnormality, the more likely it was to be a tear. Great, this is 59. We will see this study here just in a second. In 57 patients they identified in the same study, only one sulcus in the anterosuperior quadrant of the labrum was identified. So only one. And this is actually the study that led to the easy way of approaching the hip labrum, because in 57 only one had a sulcus in the anterosuperior quadrant. That means everything you see there is a tear. And it goes on, it is the belief of these authors that these recesses do exist. However, an isolated anterosuperior labral sulcus should be considered the exception, and this is where I disagree, rather than the rule, and the adjacent labrum should be closely scrutinized if considering this diagnosis. I think this is true. We need to look at the adjacent labrum very carefully, but these sulci or recesses are not an exception. They are way more common in my experience than what they think here, or what they wrote here. So we are now at this point where I offer you a choice, at least by the end of this talk, whether you want to take the red pill or the blue pill. You can just think everything I'm talking about here is just rubbish. You go with the current literature, easy way, anterosuperior, everything is a tear. What the image I showed you, you think is a tear, is fine. But if you're open to it, follow along with my argumentation that I will lay out now. And then at the end, you will have to make a call what you think or what we should do, or we keep continuing the discussion. That's probably the best way to do it. But yeah, let's dive in. So I showed you already this publication where there was a difference in the PDF and in the web version with the correction of the clock. So I call this now the red clock and this the ortho clock. This is how the surgeons use it. This is how many radiologists use it, me included. So then we go to this article. Now, this article here is one of these defining articles when it comes to this easy way method, differentiation between an anterior labral recess and the normal variant and the labral tear. They are using this clock, nicely illustrated here. No doubt they are not using the middle here or anything like that. So this is how they assessed the MRI with this clock. And it is my hypothesis that the surgeon, I have not confirmed, I haven't asked them, They wouldn't know maybe anymore. But it's my understanding that surgeons use the ortho clock with the middle here, 6 o'clock, and the psoas U at this location as a 3 o'clock, slightly posterior, like I showed you this other article before. This is 12 o'clock. I think this is fairly common, and I've seen this multiple times, and even the radiology literature seems to be adapting to this. So this is from the original study here, where the surgical findings have been described. You can see in green the recesses that they found, or the sulci that they found in relation to the clock in surgery. So they saw seven recesses at the 8 o'clock position. So I plotted this down here in green, 7 at the 8 o'clock. So because 9 would be anterior, so we go for the surgeon, this would be 9, and this would be 8 o'clock for the surgeon. So we plot the 7 there. 2 at the 9 o'clock position would be here, and then 1 at the 10 o'clock position here. And this one here, this is the only recess they found in the anterosuperior quadrant, according to that study. Remember, surgically proven recess, anterosuperior quadrant, only one, because this one is anterior already. So what I did then, also I plotted the tears. So we can see 2 tears of 54 tears at the 9 o'clock position. So this would be 9 o'clock here for the surgeon. And then we have 22 and 20 at the 10 o'clock and 11 o'clock position for the surgeon, which makes it these 2 bigger bubbles here. So this is where the tears are on an anatomic view. So forget the clock. This is just purely anatomic. This is where the tear is, whatever we call the hour. Now, if I plot these onto the red clock, then you can see a problem. Because now we have 20 tears superiorly. We have 22 tears at the high anterosuperior quadrant, and we have quite a few recesses here in this anterosuperior, at least 3 here at the anterosuperior 2 o'clock position and 7 at the anterior position. And now this is where it gets interesting. They go on, and of the 10 sublabral recesses seen at surgery, 6 were identified at arthrography. So 4 recesses they were not able to identify on MRI, and 3 of them were at the 8 o'clock position and 1 at the 9 o'clock position. Defined at surgery, were not identified on MRI. So if we look at the location of these 4, so they were trying to find the 8 o'clock position and the 9 o'clock position, which the surgeon described here. So we can see 3 of the 7 here likely, and then 1 at the 9 o'clock position. So 1 here, 3 here, they described at surgery. They were trying to find them on MRI. But because they used the clock phase, and in their opinion, this is the distribution they are trying to verify the findings, it makes sense that they're trying to find the 8 o'clock recesses down here and 1 here. And obviously they didn't find any in the 8 o'clock position because they were never there to begin with, because the surgeon had it at 8 o'clock here. So I think this is where the mismatch happens. And also, if we go to the true anatomic distribution, we can see most tears will be 1 o'clock, 12 o'clock, if you use the red clock here. And then we have certainly recesses in this area here. So I think this is what's going on here with this clock mix-up in a way. But this is not proven. This is really just me thinking and plotting and trying to find an explanation why I often see these anterosuperior recesses that don't get addressed in surgery, and the surgeon even confirms that these are recesses. So whether you believe this or not, I think this is a very intriguing. Okay, coming back to this case, so what is this? I laid out the explanation, description, everything. So we described this as a complete detachment. There's no attachment to the bone, no attachment to the cartilage. The labrum itself looks normal though. Smooth transitions, smooth lines. It's a bit flat, the labrum, but that's okay. So what is it? Is this now the tear, or is this just a sulcus? Is it a healing tear? Let's have a look. Okay, so this is the case that started this whole journey for me in 2019, to be honest. And this is the pre-op scan, this is the post-op scan, and you can see this looks completely normal. This was described as a labral tear, and at the time I was convinced this is the labral tear because following the easy method at the time, everything anterosuperiorly is a labral tear. But this was completely unchanged. And let me show you what happened. So if you look at the clock phase method, the transverse ligament, we can see, goes here through this area here. So 6 o'clock is here for the surgeon, 12 o'clock here. So this makes this recess roughly at the 3 o'clock position. So for the surgeon, this is an anterior recess and not anterosuperiorly. For us on the radiology clock, this is a 2 o'clock finding, right? That's the one thing. But because this was also arthroscopically confirmed as just normal recess, not even properly documented in the written report at least. So then where is actually the true finding? I think that's the next question we have to address. So we pull in the pre-op and we pull in the post-op coronal view. And we can see on the post-op scan, as opposed to the pre-op scan, they did something here. We can see some bony outgrowths which were not present there. We can see some fissuring, we can see some irregularities. This is where they actually did the debridement and the tiny micro drilling or whatever at this location at the chondrolabral junction from a radiologist at around 12 o'clock position. And when we go back and try to replicate this here, we can see we follow here anterosuperiorly to the superior location. This tiny thing here, this irregularity here with some changes in the cartilage, that was actually the finding in arthroscopy. And I can show you here the arthroscopic image as well. Let me just find the proper image. Here, this is the finding that they did to the debridement. We can see the labrum cartilage at the back. They took this one out, and this is a delamination kind of like injury. This is not like just a straight out plain out hole or separation from the labrum from the underlying bone, because this flap here is cartilage, and this is not labrum. This is a fissure at a tear at the chondrolabral junction with a flap here, and this was the actual finding. And then they did surgery, and after surgery, that's the way it looked here. This is the post-op finding where we can see these things now looking a bit irregular, maybe also some bony irregularities now after the intervention here, which haven't been there in the pre-op scan. So this was the location of the tear. Okay, so yeah, just bringing it down to the clock again. This one here, ortho clock, 3 o'clock, and the actual true finding was here. If you follow the ortho clock, this would be at maybe between 12 o'clock and 1 o'clock. For us, it would be 12 o'clock. Okay, so let's go to the second case. Okay, so this is the second case. Again, we have the pre-op scan here, post-op scan here, and we can go to the labrum directly, and we want to see what we would have said. So we scroll through, we can see, okay, look here at roughly between 2 and 3 o'clock, we see a detachment. We can call this a labral tear and be done with it, right? But then you go to the post-op and it's still exactly the same. Nothing done again in a patient where they did arthroscopy, in a patient where they did do surgery on the labrum. They didn't do anything at all here. So where did they do the intervention? It was higher up at this location here. And we can now try to find the finding also in arthroscopy. So let me just show you this here. So we pull the arthroscopy image in, and let me just find the image there. So you can see here labrum, here cartilage, and then there is a fissure, and then they go in with the hook here. And I asked the surgeon, and he told me this is the fissure. It's not this one. This was apparently this sulcus or sublabral hole was this low signal stuff back there, where there was like a groove or like the sulcus, and this was higher up. And now let's see if we can actually see the true findings. So we go higher up. Yeah, and there it is. See, these things, these subtle things here. That's the actual tear, the fissure that we can see here. It's so subtle that you don't even see it on a true true turbospin echo sequence here. We can only see this recess or sublabral hole, and then the actual true finding up here. We can only see some mild signal changes in the cartilage. I would not have seen this on this particular sequence, but we can see it on this higher resolution 3D stuff where we can see these abnormalities here in the labrum itself. And why is that? So let me show you another case here. So this is now a case from my practice in Bern, and we do sometimes, at least for one surgeon, we used to do these isometric volumes. They do a bony segmentation out of it. This was a program. It's called Clinical Graphics. I think they discontinued this now, but they do a bony model of the hip joint. And this is a case with severe cam deformity and pincer morphology as well. A labral tear. We can briefly just illustrate this. We can see the labrum has a tear up here and also some signal changes. Then we have something here which could be a tiny cleft. Maybe here, whether this is already part of a tear or just a little sulcus is hard to say, but the true finding was actually here. You can nicely see this here where it unequivocally goes in here. So what we can do with this here is actually not click it on, but here we can do a simulation, and I want to see and illustrate you where the actual contact happens. This is a sagittal view, so let's have a look at the sagittal here. This is below the anterior inferior iliac spine, so this is roughly this location here, here at this location. This is where we can see the labral tear here in this case. This is not the best example because we have pincer and we have an extensive labrum degeneration and tearing, but this is here the typical 1 o'clock position where many of these tears actually happen, and not this more antero-inferior location, which would be more down here where the psoas tendon comes down. So let's have a look what happens if we test this case just doing flexion. So we flex the hip, and let's see where the bony contact happens. So nothing yet, 90 degrees, we go higher up, bam. So we can see the presumed bony contact here would occur at this location, which is pretty much high, very high. It's very high up, right? Then we go back to neutral. And what we can also do is now the impingement test with 90 degrees flexion, and then we start to internally rotate. So let me just do that again. So you can see the flexion, 90 degree. Similar location with the cam, you get this contact straight underneath the anterior iliac spine at what, from our perspective, would be a 1 o'clock finding. All right, so I showed you now these 3 cases, and this is now really up to you what you want to make out of it. I'm teaching this sublabral hole now since 2021 in the virtual MSK fellowship to my fellows online with a similar explanation, but I haven't realized the actual clock problem at the time. I was just assuming there was a mismatch, but I actually found the explanation for the mismatch by preparing this talk, so I think that's quite amazing, at least in my view. So for me, this is a sublabral hole, whereas if you want to call this a tear, you can do it. You will not do much harm. Tears can be asymptomatic, so even if you call it a tear, the surgeon can even believe it's a tear as well. But then if the patient doesn't have any symptoms, they will know, or you will know, 50% have asymptomatic tears anyway. So yeah, what's the point, right? But then the term sublabral hole, although used also by at least this group of surgeons for one of my teleradiology clients, I looked it up. Sublabral hole, well, there's nothing. I tried also Google, I didn't find anything in the hip. So that's kind of like strange in a way. So maybe it's not the best description, maybe it's like a deep cleft or a deep recess or sulcus. But yeah, I'm still using the hole because I kind of like it. And sometimes I've seen cases where it was not very broad and just like a little tunnel, which I cannot explain with a tear or an old healed tear or something like this. When it comes to evidence of what I showed you here, we're very low, like expert opinion, or there's no lower stage, but I think somewhere at the bottom of this pyramid, and there is a need to address this further, maybe use this hypothesis of the mismatch in the description of location to actually repeat some of these studies and see how it will be turning out. However, let's have a look at the facts for a while. I think we've established today that if the clock method is not used the same way between radiologists and surgeons, there will be 1 hour difference in the description of findings. I think that's a fact. There's no denying. People have been using it differently. There are articles showing how they used it the other way, and surgical papers using it the other way, and even radiology changing now. That's a fact. Factish is that the anterosuperior recess is more common than has been published, or that at least some authors think. I think it's more frequent. I can't give you a number, but certainly not only 1 in 54 patients or something like this. It's more common. So not everything in the anterosuperior quadrant is automatically a tear. So I think for now, I would not advise using the easy way method. I think that's just not correct anymore. And this is my guess. We might miss the actual labral tear or the control labral tear, which is a little bit higher up, like I showed you in the 2 examples or 3 examples, because we are already satisfied by calling the low anterosuperior sulcus a tear. So we see the sulcus, we call it a tear. We don't even care anymore that there is an actual finding higher up. Be done with it. Surgeon thinks we're great. We think we are great, but we're actually wrong. Okay, so this is what I think is going on. But then, should we really focus on the acetabular labrum so much? You can't see the tree, for the forest for the trees, as the English saying is. And this was a letter to the editor, I think. And a great comment here. Focusing solely on the labral pathology may set up our patients for failure by overlooking the underlying anatomic issues that precipitate these tears. This was a surgical paper. And it's true because we don't really need to look at the labrum. It's just the result of something else, and we need to address and describe, especially the cam. We need to focus on, do we have any form of dysplasia? Do we have a pincer component? And also don't forget that not all tears are symptomatic. Although, I mean, the high prevalence of tears is probably due to the fact that many of these believed asymptomatic tears will be just recesses that I just showed you. So I think these numbers are also not quite right. Anyways, but look also for ischio-femoral impingement. Look for iliopsoas problems, iliopsoas bursitis. Look for inguinal herniations, greater trochanter pain syndrome stuff, and so on. So we cannot really just go with the labral tear and be super happy that we saw a labral tear. We need to really assess the case completely and look at the underlying anatomic issues. Also, femoral antetorsion is important to look at and not just go with the labrum. Okay. And this is actually how I do it. We have these two scenarios. We see sometimes these clefts here, labrum looks normal. I just call it now clefts. This is my preferred term because the cleft doesn't really say much about whether this is an old post-traumatic injury or just a variant, whereas the sulcus kind of like implies that this is an anatomic variant. So I like the cleft. I call these clefts. They can be in the superior, anterosuperior, even supraposterior location. Just a small thing like this with a completely normal labrum, normal cartilage. Otherwise, I call it a cleft. And that would be this. And if it's a full detachment or like a high grade detachment, including the bone, so you can see this one would not be including the bone, but if it's including the bone, going all the way through, I don't see a ganglion cyst, I don't see any changes in the labrum. I call it the sublabral hole. If you're not comfortable with this because it's completely not backed up by any evidence or whatsoever, just go with a deep sulcus or a deep cleft. No, a deep cleft sounds less severe than a complete detachment or a complete tear of the base of the labrum or something like that. But keep in mind, I'm not saying you can't have labral tears here, right? So I just want to make sure you can still have intersubstance tears. You can have detachments with extension here into the labrum substance, which then would make it a complex tear. I'm really talking about those with a normal labrum, and then we want to really scrutinize if there is something more going on a little bit higher up at the 1 o'clock position using the red clock. Okay, and here are the take-home points. Check your clock method and ask your surgeons and colleagues about it. Make sure within your institution or practice, all of you guys are using the same method. Calibrate this. I would highly advise to really talk to your surgeons and make sure you're using the same one. It will be confusing, pretty confusing for many. So, and one way to get around it would be don't use the clock at all. And this is typically what I do. I don't often give the clock, and I will probably start using it less now after this talk. And I will just use anterior, anterosuperior, or high anterosuperior, low, high anterosuperior, superior, high anterosuperior, low anterosuperior, and anterior, and using these gradation rather than using concrete numbers. It's a bit less accurate. It gives a bit more room for error or for adaptation for the surgeon also, and not creating too much of a hassle for them. But I don't think it's a big issue, because once you realize that you can have these anterosuperior recesses, I think we will overcall much less. Because then, that's the second take-home point, sublabral clefts and sublabral holes exist. However you want to call them, they exist as normal findings, not causing any issues, if the labrum is otherwise completely normal. So that's the caveat that we need to keep in mind. There can still be tears at that location though. And then the true chondrolabral tear might be higher up at the 1 o'clock position using the red clock, because I showed you the biomechanical simulation where the flexion, 90 degrees internal rotation, creates a contact, at least in that particular case, at roughly the 1 o'clock position. Okay, so we can all agree, because there's completely no evidence for these things, that this needs to be properly addressed with a prospective study. Ideally, it's prospective. I don't think retrospective studies will do the trick. They need to document the sulcus arthroscopically in these cases, finding a common ground for description of location, if it actually changes anything. That's the other thing. Like the so what test maybe is not so great, but I would love to see a proper study, and I tried to initiate one while I was still active in one of the institutions for which I'm reading, but I think it's kind of like stagnated because I'm not really involved there anymore anyways. Okay, here are just some references that I used in preparation for this talk. You can check it out, and then if you want to continue the discussion or if you have any questions, please reach out to me via email. I think if you completely disagree, reach out, it's fine. We can have a discussion. You can also join here on School MSK Riot, which is a community for radiologists. It's completely free. You can just register. There's a chat function, so we can also have a chat there, or we can have a discussion there. So that would be great to see you there. Yeah, that's it. Thanks a lot for Vancouver Bone Squad again, giving me the opportunity to talk about this passion project, even if it's a bit maybe controversial, but I think that's what's happening, and I'm really excited to see if this gets properly worked up by some academics, and then we'll see. Thanks, guys.